Hi, everyone. Trigger warning. This episode includes real stories from the emergency department, including a fatal overdose. We share these stories because they matter and because they drive change. Please take care of you. Pause and step away at any time and know that you can always come back to the episode.
I'd see a patient that would overdose. I'd watch them in the hallway. We'd monitor them to make sure that they were breathing okay. And then I would discharge them with a piece of paper that was a detox list. And all of us knew it was such a farce because the patient would try and call the detox and there's no beds. So inevitably, they would just crumple up the paper and throw it away. But we all did this.
This is the Visible Voices podcast. I'm Dr. Resa Lewis, emergency physician, lifestyle medicine physician, medical educator, and your host. If you're new here, welcome. This show is about making healthcare more equitable, one visible voice at a time. Today, I'm joined by Dr. Scott Weiner, emergency physician, associate professor of emergency medicine at Harvard Medical School, and founder of system-wide substance use disorder programming. Scott's recent recognitions, and there are many, so I'm going to highlight two. He received the Arnold P. Gold Foundation Humanism in Medicine Award, and he is the McGraw Endowed Chair in Emergency Medicine. Scott's research focuses on technological innovations that improve care for patients in pain. He also looks at opioid use disorder and access to naloxone. Dr. Scott Weiner, welcome to the Visible Voices podcast.
Thank you. It's so great to be here.
It's great to have you here, and I'm delighted to be in conversation together. So let's start at the beginning. How did you first become interested in pain, in opioid use disorder, and treatment for patients with substance use disorder?
Yeah, sure. So, Resa, you and I worked many years ago on a project in Tuscany, Italy. That was actually pretty cool. We were setting up emergency medicine as a specialty in Italy, which didn't exist back then. And so I was fortunate to work a couple of months at a time there and a couple of months back in Boston and have wonderful guests like you join us and help teach and inspire the physicians that were working in emergency departments but didn't have their own specialty. And it's actually going well to this day now, 2 decades later. So thank you for that. When I would go to Italy, I'd be there for a few months and I would come back and for a few months. And I just noticed this increase in the utilization of opioids and overdoses. And it was striking. It would be a couple months would pass and the whole thing would change. And so I think there's one case that really affected me profoundly and really set my course, the work that I wanted to do after I came back to Boston permanently from working on that project. And it was a case of a young man that was injecting drugs in Boston Common. And it was a beautiful spring day, almost like it is today. And I know this because there was a photographer for the Boston Herald walking by and started taking pictures of this young man and his two friends injecting drugs wide open in Boston Common. And what happened subsequently was very unfortunate is that he passed out. He had an overdose. What a bunch of bystanders called 911. When the ambulance arrived, they tried to resuscitate him. Unfortunately, the bystanders didn't have naloxone. This was before it was widespread for bystanders. They brought him to the ED where I was working down the street. And we, of course, attempted to resuscitate him for over an hour, and we lost him. I pronounced him dead. I had the task of calling his family. And I looked at his emergency contact and I called his father and he said, "Thank you for doing the best you could. I appreciate all you tried to do. This is now the second of my 2 sons that have died from overdose." And this was shortly after my second son was born. And so I couldn't imagine a world in which these 2 things that I love so much could be taken from me for something that's so preventable. It was one of many cases that affected me and made me want to change things. And from that point on, I started really focusing on opioids and opioid use disorder.
I've never heard this story. And thank you for sharing this story. As emergency physicians, the physicians listening, this is a very credible story. I think for listeners not in healthcare, not in medicine, they might, until right now, might not have appreciated just how extensive and extreme this epidemic is. And so you clearly illustrated sort of the aha moment. And first of all, I'm so glad you shared about Italy because I was there. I was really impressed with what you were developing in terms of emergency medicine in Tuscany. I had the fortunate experience of teaching ultrasound. I too had seen the slow increase over time, opioids playing a role in terms of emergency department patients and why they came in. And I almost saw it march through time in terms of it was alcohol, and then it was prescription drug pills, and there was cannabis. And, over the last decade, and to be clear, the epidemic has been going on more than a decade, but it's really revved up in terms of use, in terms of synthetic alternatives, in terms of substances that are mixed with the drug to actually make them more potent or more affordable on the street or in other places, that it doesn't just affect a certain community or certain demographic. It's now pervasive across communities.
It's been well described that this affects all communities. It doesn't matter your background, doesn't matter your race, your ethnicity, you're rich, you're poor. It really affects all areas of our community. Unfortunately, there are disparities still. Some people think that the attention that was given to it was because the white community started to be affected. And we've also seen these tremendous decreases in recent overdose deaths amongst overall for the population, but there still are disparities amongst Black and Latino populations, for example. And so it just highlights that there's still work to be done.
I did a search in some of your publications in the scientific and medical literature, as I like to call it, and you were an author on a publication, and I quote from it. In March 2016, the CDC, that's the Centers for Disease Control and Prevention, released the CDC guideline for prescribing opioids for chronic pain, a set of voluntary recommendations for initiating and managing opioid treatment in the ambulatory setting. This voluntary federal guideline had significant intended and unintended effects.
Yes, you hit on something that I'm so passionate to talk about. I think I come at this in a lot of things in healthcare that are wrong, that people are trying to do the right thing. There's not bad actors. People are trying to do the right thing. But this was an example, the CDC opioid guidelines of 2016, which have since been updated, where I think the CDC really did want to help curb overdose deaths and reduce the number of people that were dependent unnecessarily on opioid pain medication. But you have to pay attention to these unintended consequences. And I think they're well described, and particularly the paper that you quoted, we just released recently. It was with a colleague named Dr. Catherine Warren, who's I worked with as a student, and she's a resident at the University of Washington, and she's doing great things. She found 97 articles that describe the effects of this one guideline. And some of the consequences were intended. We decreased the amount of morphine equivalents or of opioids that were being given to people. But we also saw states were taking these guidelines and making them policy. We saw insurance companies that were taking the guidelines and making them their policy. And when you do that and you become draconian and you take away the gray in guidelines, people are going to suffer. And that's what happened. And we know now that it was basically a whack-a-mole where we hit the prescription opioids, heroin became cheaper and easier to produce and purchase. People use that. And then we attacked that. And then fentanyl became cheaper and easier to procure. And you have to wonder if how much of what's happened with the epidemic was actually the result of good intention as opposed to bad actors.
I think that's a really important highlight about people aren't trying to do harm. And in fact, primum non nocere, first do no harm. Yet harmful things have happened and are happening. For audience members that aren't completely familiar, I'm wondering if you can talk about naloxone, what it does, and why, it is a public health initiative to actually have everybody carry it.
Absolutely. So another one of my favorite topics. So thank you for bringing this up, Resa. So
I was an audience plant.
Yeah, thank you. But that was perfect. So naloxone is a molecule. The brand name's Narcan. I mentioned that just because people use the two interchangeably, almost like Kleenex and tissue paper. But it's a molecule, and what it is an opioid antagonist. And so if you've got opioids in your system, they attach to the receptors that are in your brain that are looking for opioids. If you have too many opioids on board, and you give naloxone, it displaces the opioid and reverses the effect. And so the practical point of this is that if you're having an overdose and you give naloxone, then you can reverse that overdose and you can save their life. The way that opioids cause overdose is they actually make you stop breathing. We've got our primitive lizard brain that says that you should be breathing all the time. Opioids take that away if you take too many of them. And so this reverses that, and people don't die from overdose, from asphyxiation, basically. The miraculous thing about this drug is it's extremely safe. There are very few side effects, and you can give it a variety of ways. You can give it by injection or IV, like we do in the hospital. You can use it. You can give it by a nebulizer, which sometimes they'll do in ambulances, and you can do it as a nasal spray. And so for the past several years, we've seen this real promulgation of the nasal spray getting into the hands of community members, of bystanders, and schools, another initiative I'm working really hard on. Because the more we can blanket a community with naloxone, the better chance we're going to have to save an overdose. Just like fire hydrants, fire extinguishers, defibrillators, you want to have them positioned throughout the community so that you can use them when they're needed. And naloxone is very similar to that concept.
Keeping on Opioid Epidemic 101, for audience members that aren't sure, like, what do we mean by an opioid? Like, which drugs fall in that category? Alcohol is not an opioid. Nicotine is not an opioid, although arguably addiction and some of the pathways in the brain are similar. But what do you mean when you say opioids?
Yeah, sure. It's a great question. There's also, you'll hear people say opiates too, and they sometimes use those interchangeably. But strictly speaking, opioids are things that come from the opium poppy plant. So, like old opium that people have used for thousands of years. Heroin comes from the poppy plant as well. And then we've got synthetic and semi-synthetic ones that are made entirely or partially in labs. And these are medications that we prescribe: oxycodone, hydrocodone. You've heard of codeine. And then there's some that we both prescribe, but are also found on the non-medical market. And the classic one nowadays is fentanyl. Fentanyl, you and I use it in the ED for patients. We use it for sedation. We use it for pain control. But it's actually made its way onto the non-medical market now, and it's a very potent opioid. It's probably important for the listeners to know, why do these exist? Like, why do we even have opioid receptors in the brain in the first place? Why would the brain be conditioned for this? And I think that's interesting in itself, is that you and I have endogenous opioids. When you do something that feels good, that you eat a meal you love, you go for a run, you do something positive, your brain releases these and you feel good. Unfortunately, these other opioids that you take from external sources really do hijack that, and they give the brain this false sense of joy that is not natural. And eventually the receptors become more upregulated, your brain makes more of them, and then you become addicted to them.
So I want to go into two aspects of stigma. Stigma towards patients with substance use disorder, and stigma towards carrying Narcan. And that may be a surprising stigma for audience members. Let's first start as stigma for patients with substance use disorder, and specifically opioid use disorder.
Yeah, so stigma is one of the biggest barriers that we have to people seeking treatment. People are ashamed of it. We've pushed people with substance use disorders into a box. You think of someone that has cancer, right? No fault of their own, and we have GoFundMes and we have 5Ks and we do everything we can to try and support them. Substance use disorder, of course, there's always a choice at the very beginning of use, but often you have to look at why that happened. And we know very, very clearly now that it relates to social determinants of health, adverse childhood events, other trauma that portends drug use in the first place. So you can make the argument that this was also of no choice of their own. And once the drug use starts, we know it's a disease. We know that the brain changes. We know that it's classified as a disorder. And so, but we treat this so differently. We're ashamed. We talk about it in hushed tones. In the hospital, I think that the stigma has been pervasive. We're trying our best to change this. Where even the own medical staff would treat patients poorly. I've seen people give naloxone punitively, like a high dose, to put them into withdrawal because that's going to teach them a lesson, or put them in the hallway and discharge them with a detox list and say, get out of here, treat them poorly. And getting back to what I mentioned before about, I don't think that there are bad actors. People aren't trying to hurt others. I think that this is something it's learned because of helplessness. For many, many decades, people have felt like they had nothing to do to help. And I think that's really where the stigma comes from. It's a frustration that you can't help this person on the street that is suffering. This frustration is providers, healthcare professionals, doctors, nurses, PAs, residents, everybody, that we can't change the course of this person's life. And so we react negatively. And I think that extends throughout the community as well, too. But we're trying to change that paradigm, because naloxone can save their life. You can't recover if you're dead. And then there's medications and other treatments that are available that we know work. And so let's save their life and hold our judgment and give them a second chance to then get into recovery. So this is a lot of the work that we try and do, is break down this stigma. You brought up the other one too, which is stigma at the pharmacy level. And so we know there are studies of this too, where people go to the pharmacy to get naloxone and they experience stigma. And again, we're working on that where there's guidelines that are being released. There's teaching that's happening to try and change that narrative. Interestingly, you mentioned the part about the insurance. So like if I go to the pharmacy and I ask for naloxone, in my state, in Massachusetts, by law, it's $0 copay, which is great, but it goes on my insurance. And so people always wonder, well, does that mean that the insurer or someone else is going to see this medication and they're going to think it's for me? And I think increasingly that's changing. We're understanding the importance of this and that responsible bystanders and family members are obtaining it for their loved ones. But I do think that it calls for a paradigm shift, and we need to think about naloxone in a way that the classic, like you go to the pharmacy to get it, it is not necessarily the best thing. This is why we're seeing things all over across the country, like vending machines and boxes, harm reduction organizations that are distributing it. We're trying to get it in every school in the country. All of these are important to make it where you blanket the community. You make it almost like a herd immunity like we do for vaccines, because you're going to help other people by carrying it.
So clear. And I appreciate that walkthrough. And you are now an audience plant for me because you've highlighted literally all the steps that I've experienced in my professional journey, being the resident doctor, having a patient come in, and the patient, I didn't know about Narcan, but watching people senior to me ordering the punitive dose of Narcan to reverse the patient. And then over time, that dosage being more therapeutic and kind towards a safe withdrawal level for the patient. And then the evolution to, I myself carry Narcan. I've shared with you, I used it to resuscitate someone on a Philadelphia public transportation. And there was sort of judgmental comments made towards the fact that we resuscitated this person. And I was a little surprised, not surprised, because there is this stigma and this blaming the victim. And I want to bring in, for people that perhaps maybe aren't as familiar with Narcan, but they might be familiar with methadone, and they might be familiar with Suboxone.
Yeah, it's a great question. And so it's important to know the distinction between them. Naloxone isn't a treatment. It doesn't treat your opioid use disorder. It just reverses the overdose. And it can wear off too. So if someone goes and uses the next day, they could overdose again. So it's not a treatment. It's a life preserver. It's a defibrillator. It's a fire extinguisher. It's not taking care of the underlying problem, but it's giving that person another chance, another day to live, another day to make choices, which might include recovery. Once they want treatment, then there's medication. And you mentioned two of them. I'm also still stigmatized, but I think we're working on breaking that down as well. And one of them is buprenorphine, which is the trade name is Suboxone, which you mentioned. And then the other one is methadone. And what they do is, the first one is buprenorphine. It works on those same opioid receptors, but it doesn't fully activate the receptor, sorry. And so it takes away withdrawal, so people don't, and it takes away cravings, so people don't feel like they need to use opioids. And it works really well. Methadone is a full opioid, but it's a very long acting one, so it doesn't lead to euphoria. And it maintains the individual without needing to use opioids. Both have pros and cons. Both are usually, months to years to lifelong treatment, just like we would do for any chronic medical condition like diabetes or blood pressure. But they work. There's so many studies that show that they work. They save lives. They get people back to society, get people working again, back to their families, taking care of all the challenges that we see when they have an active use disorder. So I guess just the short answer to your question is naloxone is saving their life. I guess I'm gonna make a new analogy. That's the life preserver, and buprenorphine and methadone is teaching them how to swim.
Fill us in a little bit on where naloxone and Narcan vending machines may be.
It's increasing across communities, which is amazing to see. We've talked before about work in Colorado, where I think you've worked, and now in several places they have old repurposed newspaper dispensers. Some of the younger members listening won't know what a newspaper vending machine is. It used to put a quarter in and you get a newspaper out. But they've repurposed those so they now have naloxone in them. Other communities, there's a great initiative based in New York that's now expanding called Matters. That they've set up, I think they have 30 full vending machines now. These are things like, you would normally go to buy a candy bar and a Coca-Cola, but they actually have naloxone, and they've got other harm reduction supplies, things to prevent infection. And you just walk up and you push, A3 or whatever, and it dispenses naloxone. Again, in my state of Massachusetts, you can go to ucan.info and you can just order naloxone. They'll mail it to your front door with no questions asked. So we're starting to see these initiatives all over the place. We've worked on one in the city of Boston too, to try and station them at every public transport station. We started with the Red Line, which is one line in Boston, and there's an initiative to try and expand that. I think if we get to this point where it's just ubiquitous, we're going to save lives. And that's what this is all about.
What I love is this is healthcare design. This is putting the end user at the center of the design process to make, for in this case, Narcan available and publicly accessible as part of a public health initiative in terms of treatment. I want to talk about the prevention arm, which is often coupled with education. You and I talked about elementary, middle school, high school. Children are educated these days increasingly about personal finance or about safe sex, maybe about tobacco smoking. Where are we in terms of educating our youth about opioids?
It's abysmal. It really needs work. So that my personal anecdote from this is that I had a motivated Harvard College student named Suhani Mitragotri who approached me a couple of years ago, and she said, just a college student, I graduated recently from public high school in Massachusetts, and we learned about tobacco and alcohol and marijuana and vaping, and we didn't talk about opioids at all. And I'm confused because I'm looking in the news, and this is the number one killer of so many people. It's the number one cause of accidental death amongst adults. It's the number 3 killer of adolescents. So why aren't we talking about it? And so I went home, and my kids were still in high school at that time, and I at the dinner table, I said, hey, did you guys learn about opioids when you were in high school? And they're like, no, we didn't talk about it. So like the answer
How did the no go again?
Yeah, I was like, no, two teenage boys. So no, but we did dive into it. And then we looked at the recently revamped health curriculum for the state. And I looked through the whole thing, and I didn't see the word opioid. I didn't see the word naloxone, and I control F'd it. And I saw one time it said opioid. I'm like, what are we doing? It's killing people in our community. There are kids in high school whose family members have opioid use disorder. There are kids that are coming home to other people that are using or having overdose, and they don't know how to do it. It's just like you mentioned, like personal finance. Like we all have to know how to do this. And so we developed a curriculum. We had a broad base of community organizations that endorsed it, and we taught it to about 1,000 students last year. And then this year, students from Harvard and Northeastern University have kind of taken it over, and they're going out and doing trainings. And then now there's a bigger initiative called Response, which is led by a phenomenal doctor named Holly Geyer at Mayo in Arizona, under the Naloxone Project, which is a nonprofit that I work with. We're trying to get this into every school in the country because we all need to know it. It's just like CPR. Everyone should know how to use it. Doesn't matter who you're going to save. If you're at the airport, somewhere else, someone has a cardiac arrest. I strongly believe that as a society, we need to look out for one another, and this is a way that you can do it.
And AI. I would be remiss if I didn't bring up AI. It's a part of every conversation, every healthcare conversation, every education conversation. Where do you see AI playing a role in the work you're doing with Narcan?
It's interesting. I'm going to take a different approach to this question because I was having this conversation this weekend with some friends, and also one of my sons just graduated from college, and we're navigating the job market, and we're thinking of which jobs are AI proof going forward, right? And this is a classic example where I don't see a lot of role for AI kind of taking over this human connection where we're working together, we're taking care of one another, we're teaching, we're interacting, because we know that they say that kind of like isolation and social distancing is one of the reasons why people have addiction in the first place, and depression, and so a whole host of behavioral health problems. So this is a place where we kind of need to separate it and say, like, the AI chatbot or the AI instructor or the AI, this is not the solution here. The solution here is actually a more human connection.
Yeah.
So I'm trying not to skirt the question, but I think that the human connection is so important here as an antidote.
That and I could see how there is probably chat box for people that are trying to, almost like their sober buddy or their person to kind of keep them on track if they're trying to sort of make some lifestyle changes to not use technology. I've spoken with another emergency medicine toxicologist who talked about some of the wearables that can detect if someone is sort of feeling withdrawal or craving symptoms. Have you done any work or research in those?
I love this topic too, because we've tried, and I think it shows promise. Just in disclosure, I did work with a group called Opioid, which is based in North Carolina, and they have an AI-based wearable platform. And it seems like it's working well for individuals that are on treatment and to make sure that they're continuing with their treatment. The theory is this, is like, say you have a patient taking methadone or buprenorphine, and you're a busy doctor and you can't keep tabs on all your patients. It's just physically, it's not possible. There's not enough hours in the day. But if a patient has a wearable, that indicates, ooh, they might not be taking their medication, because it can actually detect when you're taking your medicine, or that it's they're having withdrawal symptoms, because it can also detect withdrawal symptoms. Then there can be a ping to the doctor or the nurse, whoever's following the patient, and they can reach out proactively and address that. So we actually did a study. I got to present it in Hawaii in January, which was a total pain to have to go to Hawaii in January and present, especially leaving Boston. Yeah, but we did a preliminary study of this wearable in patients that were being treated in a telehealth opioid use disorder group, and we found that about half of them wore it all the time, and maybe out of that, maybe like 2/3 of them we had usable signal. So you have to overcome this barrier about utilization. It's not going to be for everybody, but I think that there is a portion of the population with substance use disorder for which it will work well. I do worry about the adding disparities, because someone has to pay for it. And, a lot of the patients that I take care of are undomiciled, and, to put on a $300 wearable, it's going to be gone. You can imagine another patient that might be stable in treatment, that's back to the labor force, has a stable housing environment, that they might be perfect just to make sure that they're continuing with their treatment and they don't need additional help. So yeah, I think there's room for that.
I'm wondering if you can quote numbers, share with the audience how common, overdoses are coming into the emergency department, and, what has been the change in trends over time.
We actually just published this as well too. We did a study looking at how you can do metrics for how well we're doing in the emergency department, how often we're prescribing naloxone, how often we're giving out buprenorphine or methadone. And from a huge registry from the American College of Emergency Physicians, it was 0.5. So 1 in every 200 visits had to do with opioids. We're like primarily an opioid-related visit. And so, my ED, we see about, I don't know, we're kind of like medium size. We see about 200 patients a day. It's pretty much guaranteed that at least one of them would be opioid-related. You take that across the country too. Some places are going to be a lot more, like in Philly, you'll probably see more overdoses than you might in a small rural hospital, where it happens, but not as frequently. So let's say 0.5%. Yeah. Trends over time, I think that we saw this huge increase for a long time. And now I think it's starting to finally come down. And the numbers are really, really encouraging. We hit this peak kind of a couple of years after COVID. In the past 2 years, we've had this marked decline in the numbers of overdose-related deaths across the country. I just read actually this morning that in my state, where we hit over 2,000 deaths per year for many years, we just, for the first time in several years, are below 1,000 deaths in the last calendar year. It's going down, which is great. This is not the time to stop, though, right? Like we can't declare victory. This is still abnormal. Like you still have 1,000 people dying every year, right? So this is not in one state. So it's not the time to back off, but it means that what we're doing is working.
And is this, in your determination, because of Narcan?
No. It's so multifactorial. It's impossible to pin it down. So naloxone is one thing. Education is another thing. Expanding access of medication for opioid use disorder like buprenorphine and methadone is another thing. There's also the other side of the equation, that the drug supply is changing. We've spoken before. You've probably heard, or the listeners have probably heard of something called xylazine. There's another one called medetomidine, which are these other substances which are in the non-medical drug supply, and they're sedatives. And so there's actually a theory that the makers of these non-medical opioids, the cartels or the clandestine laboratories or whatever, are adding this in because it actually keeps people alive. It's not it's more difficult to overdose on these, and the use decreases because you're more sedated for a longer period of time. So we can't even take all the credit for this. Like some of this is actually the illicit drug manufacturers are changing their behavior as well. But I like to think that, someone asked me that question recently. I'd like to think that at least 50% of this benefit is the work that we're all trying to do.
As always, most things are multifactorial. Scott, when did you realize you had a voice, and when did you start using your voice?
I guess it's appropriate for the title of this podcast. I'd have to say it was one paper that we published that took me a little by surprise. So I had this very simple question. At this point, this is in the mid 2010s, like 2014, 15. I'd see a patient that would overdose. I'd watch them in the hallway. We'd monitor them to make sure that they were breathing okay. And then I would discharge them with a piece of paper that was a detox list. And all of us knew it was such a farce, because the patient would try and call the detox and there's no beds. So inevitably they would just crumple up the paper and throw it away. But we all did this in emergency department. You probably did it too. We all did this. So my question was very simple. I said, how many of those individuals that we're discharging would be dead in a year? Because when we look at cardiovascular disease, when you ask emergency physicians what their acceptance rate is, they're like under 1% of my discharge paper patients should be dead within a year, right? Like that's like an upper limit. It should be a lot lower than that. But what was the number? So we did this study, and actually I submitted it to a big journal in emergency medicine, and it got rejected. And it's the first and only time in my career
As one does.
Right. But first and only time in my career when I wrote back to them, I'm like, are you sure you want to reject this? I worked with the editor and we actually modified it. And the finding was that 5.5% of those individuals were dead in a year. 1 in 20 were dead in a year. So like out of every 20 people I'm seeing with this condition, I'm discharging, they would be dead in a year. And it really took off. It got media press. It got press attention. And so I talked to CNN, I talked to a bunch of newspapers, and it really showed me that, like, because I'm a researcher, I'm a health services researcher, that having these really impactful findings and really simple and concrete and easy to understand, it has broad spread voice. And so people can really grasp onto that. Like, oh my gosh, this is worse than a person that's going to the catheterization lab with a heart attack. Their mortality is about the same. So we do all these things for that heart attack patient, and then we're giving a piece of paper to this patient that has a similar mortality. And so I've been honored to hear that study quoted many times in talks, including by the director of the National Institutes on Drug Abuse and different. It pops up all the time, and it makes me really proud because I felt like that was a wake up call for people.
It's such a great story. And I want to circle back to the story with which you opened. How do you think about that story now, that story of the overdose and death that happened on the Boston Common that started this whole journey out for you?
It's very clear. That photographer was taking these photos, and it's actually striking because those were published in the Boston Herald. There's these pictures, and you can see the progression. You can see when they were using, he was taking pictures. And then the next one is he's lying down, blue. And then the next one is the paramedics are there. First of all, like, there was police there that were handcuffing and taking away his friends, which is a whole other issue. But the paramedics were there trying to resuscitate him. And then what I know, which is he came to the ED and died. But what if that photographer had naloxone and not just a camera? That the whole course of that entire, all of their lives would be different. He would likely still be alive, at least that day. At least he would have another chance. So it's just, you imagine, like, what if you had that naloxone that you carry, right? Like, what if you had your phone, but you didn't have that person on the subway that you reversed? They could have been dead. So it's so simple. It just carry it. You never know.
You led me right into my next sort of nudge about micro skills, actions, small behaviors that audience members can take. So they're motivated now. How can someone listening today get access to naloxone, carry it, and know and learn what to do with it?
I have to quote one of my dear friends and heroes is Don Stater, who's an emergency and addiction and pain doctor in Colorado. He's the director of the Naloxone Project, and I'm really lucky to work with him. He said, like, you need 3 things to learn how to use naloxone. You need a brain, because you need to recognize that there's overdose. You need a heart, because you need to care about someone. And you need an opposable thumb, because you just have to push the plunger into their nose. Like, those are the 3 things. And I love that. And I love that metaphor. It's really simple to use. There's training all over. If anybody does a CPR class, they now teach about this as well. There's tons of online resources, including at the Naloxone Project. You can go there. Local departments of public health, local harm reduction agencies. There are trainings everywhere. You just have to Google it. You'll find something in your environment.
This would be a use for AI. People could use AI to sort of generate access to Narcan and Narcan trainings in their local area.
I'm sure if you plug this into Chat, GPT or Claude or whatever, it would say, like, teach me how to use naloxone and where can I get it? Yeah, we'd do it like that.
For the physicians, and specifically for the emergency physicians, what would you like to see them do? What small action they can take the next time this is one of their patients in the emergency department?
One word, and this is a burnout treatment, and this is a longevity treatment. Advocacy. Like, we got to be at the state houses. We got to be at our town meetings. We got to be up on the federal hill. I hear over and over again how infrequently they see physicians there. And when we go there, we're revered. It's like the only place where that happens any longer. Where they're like, wow, you're taking care of our constituents. You're trying to do the best for them. You're our direct representative. And they listen to us. Some of the best professional satisfaction I've gained in recent years has been from the relationships I've developed with some legislators. We've tried to work on like a bulk purchasing fund for naloxone for our state so we could dispense it more easily. We've tried to work on this implementation of naloxone on the subway lines as well too. Tried to work on the education in the schools. We have a bill that's still active that would mandate this education happens. So it gives me such satisfaction because I'm not banging my head against a wall when I'm working a shift by something I'm frustrated with. I'm actually changing that, or I'm working to change it so the next shift will be better. Advocacy.
And what would be one small step for physicians to take towards advocacy if they're not like, I don't know how to get involved. I don't know who to call. And, I'm not an advocate. What do I do?
My personal journey was with my state specialty society, and every physician has their own specialty society, and many of them have state societies as well. Just start to show up. Just be the person that's in the back of the room listening in. You'll learn what's happening, and there'll be calls to action. There'll be lobby days, times when you can go to the state house and talk, and just listen to start. You don't even need to say anything. But those opportunities exist for every single specialty, and it just brings so much satisfaction.
Dr. Scott Weiner, if people want to follow you, your work, and learn more about what's coming in terms of your research.
Thank you. Yeah, I post fairly commonly on LinkedIn. That's probably the place that I use the most. Whenever we have a new paper that comes out or something that's exciting happening, I try to post it there. And so, you can follow me on LinkedIn. Is probably the best way.
You are a visible voice. You are a storyteller, and you are an advocate. Thank you so much for joining me on the Visible Voices podcast today.
Thank you. It's been a pleasure.
The Visible Voices podcast amplifies voices in the healthcare, equity, and innovation spaces. Our team includes Dr. Giuliano DePortu and me, Dr. Resa E. Lewis. Find me at Resa E. Lewis, MD on social media, or visit thevisiblevoicespodcast.com. Find us wherever you listen to podcasts and watch our episodes on YouTube. This podcast is for education and entertainment purposes only. The views and opinions expressed by hosts and guests are their own and do not reflect those of their employers or institutions. Guest appearances do not imply endorsement of any product, service, or organization. Information shared here is intended for general informational purposes only, reflects the time of recording, and should never substitute for clinical judgment or individualized medical advice. No physician-patient relationship is created by listening to or watching this podcast. Together, we're making healthcare more equitable, one visible voice at a time.